in my way. They just kind of got to stand back that far from the camera. So.
Well, you could get closer if you wanted to. You're just taking up more, of course. I mean, you could pace around.
The problem is I can't pace in front.
Oh, yeah. Well, the PowerPoint is going to be in the big screen anyway for the online people, so you don't have to worry about, logging the camera up the PowerPoint in the little window. Okay.
So can I get started?
Yeah. Yeah, you can go ahead and just give me a time when you want me to
advance.
Yeah, advance.
Well, thank you all for coming today to hear this. I'm going to tell you a little bit about sort of what I plan to cover today, and I'll start off with sort of telling you why this topic, cochlear implants, is of interest to me. I've been involved with cochlear implants now for 17 years, and that's because my second son, my youngest son, was born without any hearing and received his first cochlear implant when he was 2 years old. So since that time, my family has sort of eat, drink, and sleep cochlear implants. My wife is also a speech pathologist. She was before my son was born, but she had only done a little bit of work with hearing impaired children, and now she's actually a clinical supervisor at a place that specializes, a nonprofit that specializes in therapy for hearing impaired children. So all we ever talk about is hearing impairment and that kind of thing. Every day she comes home and tells me all about the new hearing impaired kids who are coming into the program, that kind of thing. And of course, we live it every day with our own son who has cochlear implants as well. So what I'm going to do today here is very briefly some of these things. I'm going to talk some about just how normal hearing works, the types of hearing loss, both for adults and children, some of the causes of hearing loss, a very brief history about cochlear implants, some general statistics on cochlear implants, a little bit about the candidacy for cochlear implants. Who is a candidate to receive a cochlear implant? Then how the implants work, external equipment. I'll show you a picture of that. I meant to bring some with me today, but I forgot to get some of my son's backup equipment. I'm going to talk to you some about speech banana. Have you heard of the speech banana? Well, I'll show you the speech banana superimposed on the audiogram. So we'll talk some about that. And then I'm going to show you some examples of an unaided audiogram and then my son's actual audiogram with the cochlear implants. So that's what I'm going to do today. The first thing is just real briefly how hearing works. This is a little bit bigger, okay, but anyway, you all know the sound comes in through the ear and down the ear canal. It vibrates the eardrum-like ear, then it sends all these little bones to vibrating, and then this is the cochlea. This part right here is called the middle ear, and then the cochlea right here is the inner ear. And all these vibrations eventually get their way to the cochlea. The cochlea is filled with fluid, and that fluid starts to vibrate. And inside the cochlea, in all these little terms, there are what's called hair cells. And once the fluid starts to vibrate, the hair cells are activated, and then those turn into electrical impulses that go to the auditory nerves of the brain. So that's basically how hearing works for normal hearing people. The types of hearing loss.
Oh, sorry. Yeah, people said they can't hear very well. I don't know if they're going to turn all the way up in the chin. Okay, yeah, we tested it out.
So just real briefly, the types of hearing loss. The first one is conductive hearing loss. Conductive hearing loss is when you're having a problem with the middle ear. And that can be caused by different conditions. ear infection. When a child has an ear infection, you may not hear normally. That's a conductive hearing loss because you've got an infection there with the eardrum, that kind of thing. There's also sensory neural hearing loss right here, and that's where you're having problems with the inner ear, the cochlea, or either the auditory nerve. So sensory neural hearing loss, mixed combination of these two. And this right here, auditory neuropathy spectrum disorder. This is a very complicated type of hearing loss. The cochlea, the auditory nerve, seem to be operating to some extent, but what's happening is the sounds aren't organized in such a way that the brain can make sense of them. So this one is a very complicated, sort of difficult type of hearing loss. On some tests, a child could look like he has normal hearing. On another test, it looks like there's an absence of any hearing. So auditory neuropathy is a very complicated type of hearing loss. Next.
There are pictures on the slide. It may take a little moment to load.
So what about hearing loss in adults? Well, as we all know, there's increased presence of hearing loss in age, 18% of 45 to 64, girls 30% 65 to 74, and then by the time you get about 75, almost half the population has some kind of hearing loss. And of course, as the baby boomers age, we're having even more and more people with hearing loss. There are all sorts of causes for this hearing loss. Noise injuries, people who've worked in very noisy careers, pilots, that kind of thing, people who've been around a lot of firearms, loud rock music, that kind of thing. There are also several illnesses that can cause hearing loss in older adults. Heart conditions can affect hearing, strokes can affect hearing. There's another disease called otosclerosis that will also affect the middle ear, and that one has to be surgically treated. There are also ototoxic medicines. There are some medications that people take that can destroy their hearing. What's interesting about this one is, if you know Rush Limbaugh, he has a cochlear implant. It seems to be that he lost his hearing because of his own drug use when he was taking all those very powerful pain medications and stuff like that, using those drugs. More than likely, from what my understanding is, destroyed his own hearing because of the toxicity from those drugs. There's also presbycusis, which is just age-related sensory neural hearing loss. But as we age, both the cochlea, that kind of thing, we have sensory neural hearing loss. It's the third most prevalent condition behind arthritis, hypertension in older adults. But if you look at the older adults who have hearing loss, only 25% of them use some kind of hearing aid, something to improve their hearing. So only a small percentage of those people who really need some kind of help with their hearing are getting it. And then only 5% of these people actually need some kind of medical or surgical treatment. And this is where cochlear implants would come in for older adults. Next, for children, it's really hard to get a good estimate on the number of children with hearing loss. And even on the CDC's website or the National Institute of Deafness and other communication disorders website, one of the National Institute of Health people, their range is from 1.1 to 5 children per 1,000 have a hearing loss. That's a pretty big range. Maybe the truth is somewhere in the middle there. It is the most common, put in quotation marks, disability, because I know that some people don't regard hearing loss as disability. If you look at the children with hearing loss, about 60% are mild to moderate, and 40% are severe to profound. And just like with the adults, there are multiple etymologies or causes for child hearing loss. Next. So what about these causes for child hearing loss? The first type I'll talk about is congenital hearing loss. Congenital hearing loss means you're born with the hearing loss. And out of the children who are born with hearing loss, about 50 to 60% are genetic. They've identified a gene now, and parents can go and have their children tested, and they can see if their hearing loss is indeed genetic at this point. About 30% of those children have some kind of syndrome, where hearing loss is just a part of the overall syndrome that may involve multiple issues with the children. Another 25% of children born without any hearing, there are maternal infections, birth complications, or head trauma. Some of y'all may be aware that the CMV virus is very dangerous for a woman to have while she's pregnant. That can cause hearing loss in children. Also, low birth rate is associated with hearing loss. It takes 25% of children born with hearing problems were born weighing less than 5.5 pounds. And of course, you have little preemies who are born at 1 pound and things like that. You often have hearing loss associated with those preemie births. Also, children can have acquired hearing loss just like adults. One of these things is illnesses, things like meningitis, measles, mumps, influenza. All of those things can also cause hearing loss. The same thing goes for them. Other toxic drugs can destroy hearing in children. It's interesting that meningitis in and of itself can cause hearing loss in children. But many times in order to control or treat the meningitis, they have to give children very high doses of antibiotics. Many of these antibiotics, the strongest ones, are ototoxic. So if the meningitis doesn't get their hearing, the treatment of the meningitis can get their hearing. So you also have quite a few children who lose their hearing that way. Head trauma and dengue and noise induce, just like for adults, can also affect the hearing of children. So what about cochlear implants? Well, the idea has been around a really long time that you could use some kind of electrical stimulation in the cochlea to mimic or do something similar to hearing. That idea has been around for a long time. 1950 is the first recorded attempt of someone to stimulate the auditory nerve with current. A physician did this, a surgeon did this while he had a patient, opened up that kind of thing. They put an electrical current into the patient's ear and the cochlea, and the patient said he heard these different type sounds. So that's 1950. By 1972, the very first single electrode implant was commercially available. The House Ear Institute had started putting in a single channel or single electrode cochlear implant, and by 1972, it was commercially available. It wasn't until 1984, though, that this single channel implant received FDA approval for adults. So in 1984, it was no longer considered experimental. Insurance companies could begin to cover it, that kind of thing. But only for adults. Children were approved for cochlear implants in 1990. And you had to be 24 months, though, in order to get an implant. But by 2000, the FDA has now approved cochlear implants for 12-month-old children. And some of the real aggressive research centers and things like that, Indiana University Health Care Center, stuff like that, they actually implant children now down to 6 months of age. So whether or not the FDA will ever approve anything younger than 12 months is unknown, but the researchers are conducting research with even younger implantation. There are a few things that they have to worry about because with very young children, their skull is still growing, that kind of thing. When we're born, our cochlea is already fully formed, so you don't have to worry about the cochlea, but you have to worry about the positioning of some of the external equipment, that kind of thing. All right, next. So what about cochlear implants? The best estimate I can find, the most recent estimate, is worldwide there are over 200,000 people with cochlear implants. In the U.S., over 41,000 adults and over 25,000 children in the U.S. have a cochlear implant. Really, that's not very many. The estimates are from 10 to 42% of children in the U.S. who could benefit from implants are receiving them. So here again, there's a wide range here. This is a very difficult thing to track. We have almost now universal newborn screening for hearing loss. You know that when children now, before they leave the hospital, they have one of two tests, an ABR or an OAE, to check for hearing loss. I think now the estimates are about 97% of infants are undergoing newborn hearing screening before they leave the hospital. But then a lot happens after that screening, whether or not, how severe their loss is, that kind of thing. There was a study done in Georgia. Let me see, I think it was 2005. Yeah, 2005. There was a study done in Georgia and said that there were 1,500 children in Georgia with severe to profound hearing loss, and 580 of those, or just 39%, had received implants. So the large majority, or the majority of children who could benefit from a cochlear implant are still not receiving an implant. Not all people with profound deafness are implant candidates. Just because you're profoundly deaf doesn't mean you're a good candidate for an implant. I'll talk some more in a couple of minutes about sort of the candidacy for an implant. It's also very important with children that post-implant they have to receive therapy. The cochlear implant is not a magic bullet. It doesn't just fix hearing loss. You put it in and it's a done deal. No. There's a lot that has to happen therapy-wise, rehabilitation-wise, once the child is in implant. So, who is a candidate for a cochlear implant? Well, first of all, these are generalizations because as you go to different implant centers or even different individual that kind of thing, they may have slightly different qualifications or criteria for who they will implant and who they will not implant. None of the implant centers just take everybody in and say, well, you've got a hearing loss, I'll put an implant in you. That's not the way it works. And so depending on who your surgeon is, what your implant team is, where you are, the criteria may change a little bit. But in general, in order to be a candidate for an implant, both for adults and children, you have to have a bilateral, severe to profound functional hearing loss. So that means you have to have the hearing loss in both ears, not just one. You also must get little to no benefit from hearing aids. And this is where you see a lot of variation on what does it mean, little to no benefit from hearing aids. Some of them sort of use the benchmark aided word recognition scores of less than 50%. But that varies a lot by the practice, by the surgeon, that kind of thing. Also, there must be no medical contraindications to surgery. So if you can't be put under anesthesia, you can't get an implant. For children, before they ever implant the child, they have to do CT scans to make sure the cochlea is not malformed, because sometimes the problem is the cochlea is very malformed and a cochlear implant can't be inserted. Also, if the auditory nerve is not intact, a cochlear implant isn't going to help at that point. So you have to look at those contraindications to surgery as well. Also for children, like I said, right now you have to be 12 months of age in order to get an implant. You have to have a highly motivated family with appropriate expectations. This is very important. And unfortunately, sometimes you have a family with a child with severe without hearing loss, but the family just can't get its act together. And surgeons will turn those families away and say, look, until you can follow up with my directions, until you can follow up and get in a good program, that kind of thing, we're not going to implant the child. So the family also comes into this. And then the children have to be in a real rehabilitation program that supports listening and speaking communication. So that means if you have your a child is severe to profound and they're in a sign language program, most implant centers aren't going to implant that child. Because they're going to say, unless you're in a listening and speaking type of rehabilitation program, we won't implant you. This is also one of the things that parents have to make sure they're on board with in order to get them for implant. Next, how does the implant work? All right. Well, if any of you've seen the implant before, there's a piece that hooks behind the ear, just like a behind the ear hearing aid. There's also a piece right here, which is the transmitter, that is actually on the side of the head. Beneath that transmitter, beneath the skin, a magnet has been placed. And the transmitter coil also has a magnet. So this thing stays on the head because of the magnet that's been placed under the skin. And then the transmitter coil is popped on there because of the magnet. Most of the time, it's not true for all implants, but most of the implants have the microphone on the behind the ear piece. One company actually has the microphone on the transmitter coil. But the microphone picks up the sound. The sound is then converted by this behind the ear piece into electronic signals. Those are transmitted across the skin to the receiver. The receiver actually has a wire that goes from the receiver to the mastoid bone and all the way into the cochlea. And this is where the electrodes are placed. They're placed in here. Most devices now have 22 to 24 electrodes. So once the electronic signals are transmitted across the skin, the receiver, they come down this physical wire into the cochlea. Different electrodes are stimulated in different patterns, and those directly stimulate the auditory nerve. So that's basically how the implant works. The next slide shows you, this is what the external equipment looks like. This is the behind the ear piece, and then this is the transmitter coil. This is for, there are three different main manufacturers of cochlear implants, and this is a med-L device. When my son first got his implant in 1994, none of this, we didn't have these small little bitty processors. He had to wear a little bitty box that was about that big, a little bit bigger than a pocket calculator, about the size of some of our cell phones now. He wore a little box right here, and so behind the earpiece had a cord that went down to the box, and then that signal came back up and then went to the transmitter coil. But now, of course, with electronics, everything can be miniaturized. One of the big issues was power, having enough power to run this device. So most of the time they have rechargeable battery packs in here, or you can run it off hearing aid batteries. But now it's all been miniaturized, so everything's just up here on the ear. Next is the speech banana. Okay? Speech banana is very important. If you've seen an audiogram before, what we have here, these are frequencies. And these down here are decibels. So if you have a 90-degree hearing loss, 90 decibel hearing loss, that means you cannot hear anything above the 90 line. You can only hear these sounds right here: chainsaws, airplanes, helicopters, jackhammers, that kind of thing. So this is loudness over here in decibels. Sometimes we hear people say, well, I've got a 10% hearing loss. That's absolutely meaningless, because what's a 10% hearing loss? You have hearing loss in decibels. So you can have a 90 dB hearing loss, a 50 dB hearing loss, a 20 dB hearing loss. Normal hearing is anything up to like 20, 25 decibels. Now what's important is this banana-shaped thing right here, because this is where the speech sounds off. And what you want to do, whether it's with a hearing want to make sure that they can hear all of the speech sounds. So you want to have hearing at least about 20 dB level so that they can pick up these high frequency sounds along with all these other frequency sounds. Now, what used to be the case with hearing aids, you would have a hearing aid that would work fairly well in these low frequencies, but then as you got up to 1,000 hertz or so, it started dropping off. So that meant you were losing a lot of the speech sounds. And a hearing aid just can't overcome some of those problems. Even the fanciest programmable, most advanced hearing aids today can't necessarily give you what we call a flat audiogram, where you have hearing all the way across at the same decibel level. So the speech banana is very important, especially with children developing language. They need to be able to hear all of these sounds. That means they're going to have hearing at least to the 20 dB level. And that's about where normal hearing is. If you have a 10 dB hearing loss, it's still considered normal. If you have a 20 dB hearing loss, you're still considered to have normal hearing. Right? So the speech banana is very important. You've got to get the children to hear all of these different sounds in the banana at both tips. These high frequency sounds here, these over here. So that's where speech falls into our hearing. Next. This is the actual audiogram of my son. He was born in 1992. We found out when he was 15 months old that he pretty much had no hearing. And at that point, we couldn't get a cochlear implant until he was 24 months old. We had about 7 or 8 months to wait. But this is what his audiogram looks like without his cochlear implants. And you'll see here, normal over here, from a zero loss to about 25. Here's mild. Here's moderate, moderate to severe, severe, and profound. My son had a profound hearing loss. If you look here, see these zeros right here? That really means this is the limit of the machine. Audiologist puts him in a sound booth at the limit of the machine. That's 100 dB. He would hear anything. And once you get to around 100 dB, the sounds that you are getting are almost tactile. The sound is so loud that you can just feel it, that kind of thing. But my son, unaided, got no responses at 100 dB, which is the limit to the machine. Okay? So that's how profound his hearing loss was. All indication is he was born with that hearing loss. At age 2, though, he got his first cochlear implant, and his hearing was implanted. This is my son's implanted audiogram. This is how he hears with his implant. There are 2 things here, one for the left ear and one for the right ear. And the left ear is better because that is the ear that was implanted when he was 2 years old. He did not get his second implant until he was 16, and that's the right ear. And you'll notice the right ear is not doing as well as the left ear, but you'll notice that his left ear, he hears at 10 dB. So he hears all the speech sounds. So with that one cochlear implant, he was able to develop normal language, listening and speaking. This is a little bit misleading. This is his right ear that he only has implanted now for about 2 years. And it's not doing as well as the left ear. Well, why is that? And this is where it's very important because some people have suggested that children who are born hearing impaired, their parents shouldn't be making this decision to give them cochlear implants. That the children, we should wait until they're a teenager or so and let them make their own decision. And then at that point, they can decide if they want to be implanted and try to be a part of the normally hearing community, or if they want to continue in the deaf community. Well, you'll see a difference here between the 2 ears. This right ear that he has implanted at 16 will never be as good as his left ear. And this only shows you half of the story because these are pure tone thresholds. So the audiologist is sitting there and just giving a tone at these different frequencies. At that, you can see at 10 dB, my son could hear those tones at 10 dB. With his other one, they're down around 25 dB. However, this is only part of the story because along with just hearing tone is the ability to discriminate words and to hear those sounds and be able to recognize words. So with my son's left ear, the one that was implanted when he was 2, if you put him in a booth and you do an open set, that means anything upper grass, and you give him a word discrimination or word recognition task, he can score almost 100%. You can put him in a booth and put noise in the background and give him sentences. He can still score with that left ear that was implanted when he was 2 in the 95%. He hears very well with that left ear. Okay. When you only have hearing in one ear, though, one of the things that you lose is the ability to localize sound. The reason we know where a sound is coming from is because our ears can take that split-second delay from it hitting our left ear getting to our right ear, and we know that this sound's coming from over here, or this sound's coming from over here. With just one side implanted, he can't do that. He's only got unilateral hearing. This ear right here that was implanted when he was 16, even though on the audiogram it doesn't look that bad, you put him in the booth, have him work just with his right ear. With his right ear. Give him a choice of 4 words. So he's looking at a choice of 4 words. The audiologist says one of those words. He can only score about 52% correct on that. His right ear will never approach what he can do with his left ear. And you have to think about it this way. That right ear of his got no auditory stimulation for 16 years. So that auditory nerve got no stimulation at all. We know that the brain of newborns has a lot of what's called neuroplasticity, where the neurons are being hardwired, they're being dedicated to tasks, that kind of thing. When that auditory nerve is getting no stimulation, then those pathways that would have fed that, would have handled that stimulation, are being dedicated to other things. So now at 16, he's having to try to overcome that. That right ear will never be as good as his left ear. Is he glad that he got the second implant? He is. Because with the second implant, it gives him the ability, like I said, to localize. If I call his name now, he knows which way to turn. He has some idea of what room I'm in the house when I call his name. It also helps with signal-to-noise ratio, so that he hears a little bit better now in noisy environments, restaurants, cafeterias, that kind of thing. So this ear that he waited, 14 years to be implanted after the original one, is going to slowly improve, but it will never be as good as that first year. So now, the standard of care for children who are 12 months of age and are getting a cochlear implant is bilateral implants. It used to be that they would only implant one ear in children. Now the standard of care is to implant both ears. Depending on who your surgeon is, there are a few surgeons who will do both ears at the same time, operate on both ears. But here in Atlanta, what most of the surgeons do is they implant one ear, they wait a few months, 3 or 4 months, and then they implant the second ear. Now that children are being implanted bilaterally at 12 months, they're making remarkable progress. Because at 12 months of age, they have a 1-year language deficit. Now, with aggressive therapy, and my wife's clinic or nonprofit, whatever you want to call it. They have children profoundly hearing impaired come in, have their implants, 12 months, maybe the second one at 14 or 16 months, something like that. They have completely erased their language gap in 12 months. They can release those children. They don't need any more therapy sometimes within 12 months to 18 months. So in a year and a half time, those children are on par with their peers as far as language development goes. For my son, it took longer than that. He wasn't implanted until he was 2, so he had a 2-year gap that he had to close once he was implanted. So he was in therapy for how many years? At least 5 years. I think by the time he was 7, we had finished with therapy.
Sorry.
So now it's amazing. The younger we can implant the children, the sooner they can close that gap and eliminate that gap in their language. So the world has changed a lot. We were waiting around when my son was 15 months old and his hearing loss was identified. We had to wait for 7 agonizing months before he could be implanted. He had to be 2 years of age. He turned 2 on August 31st. He was implanted on September 1st, as soon as we could get it done. So implants really are changing the world for these people, the hearing impaired people who are getting them. I used to participate in a lot of the activities. They have the Georgia Peach Cochlear Implant Association. Most of the association are older adults who've got implants. It's amazing. You can go and talk to some of those adults. They had some traumatic events. They lost their hearing. They got implanted very soon afterwards. You wouldn't even know they have a hearing loss. Their vocal quality has remained the same, that kind of thing. It's just amazing. You never guess that they have a hearing loss. My son, he uses the telephone. He watches movies, TV. There's no captioning, that kind of thing. He's just like all of his hearing peers. He went to his neighborhood school, never had an IEP. The only accommodation he had in his education is when he was very young, used the sound-filled FM system, and then once he got older, he used a portable FM system where the teacher was mic'd, and he would sit this little thing on the desk. That's the only accommodation he had in his public education, and that is through a 504 plan, not an IEP. So the potential is just incredible with these cochlear implants for both children and for adults. So it really can change their world. Right. So that's what I have. Are there questions? Yes?
So after the children get cochlear implants, would they get a speech pathologist, or is it someone more specific suggestion?
Well, I mean, there are a lot of speech pathologists now, like my wife, who have specialized training in working with children with hearing impairment. A lot of speech pathologists still haven't been trained that well in what do you do with a cochlear implanted child? Where do you start? Because you have to remember, these children get an implant, their brain never heard a sound before. They don't know what it is. So you have to start in very incrementally slow steps, teaching their brain, what to do with that sound and that kind of thing. So a lot of speech pathologists still treat hearing impairment, and there's no problem with that. It's just that now it's very important really to find a speech pathologist who has additional training in how to work with cochlear implanted children. My wife has an additional certification that it took her, I think, 6 years to get, and she had to pass a national test. So she has a very specialized training now. The therapy that she does is called auditory verbal therapy. It's probably the most aggressive therapy for children who receive implants. They also have children in their center who use hearing aids. They have some children who have an implant in one ear and a hearing aid in the other ear, that kind of thing. So they are very specialized. It's a very aggressive therapy. They don't encourage any lip reading. Now, my son is good at lip reading, but he is good, but he was not taught to read with us. They go out of their way to make sure that the children are developing auditory skills with the new access that they have to sound through the cochlear implant. So my son, he loves to get up in the morning. He doesn't put on his implant. He comes downstairs and watches Sports Center without being able to hear it, that kind of thing. And when we need to talk to him, he pretty much just reads lips with us. So he has learned that skill, but it wasn't a skill that was taught to him. Yeah. That's an interesting question because we lived in Macon at the time, and the place where my son got therapy and my wife works right now was in Atlanta. So we started making trips to Atlanta, and we visited all the different places where he could get therapy once he was implanted. The Atlanta Speech School, they have quite a few cochlear implanted children. My wife's in there, usually has from 30 to 50 children in their program to have cochlear implants. And they have very strict guidelines about the use of manual communication. So when we went there, they told us, no, you cannot sign with your kid because he'll get too comfortable with the visual communication, and then once he gets his implant, it'll be too big of a jolt to him to try to use the sound. I said, show me the research. Show me the research. Because my background is in linguistics. And I know how important child language is. And I know how important it is for the brain to start learning some kind of language as soon as possible. So my wife and I said, no, we won't do it. And I told my wife, if they insist that we don't use sign, we'll find some other place. They finally relented. So at that point, my wife and I started learning to sign, and my son started learning to sign. But we knew it was only a stopgap measure. We knew as soon as he got the implant, we would drop the sign so that he would really have to focus on using the new auditory input. So, yeah, we signed with him, and I was just like any other parent. I mean, the first time, he's 15 months old, he walks up to the sliding glass door, and he does bird. That was his first true word for us. I mean, I was just ecstatic. Here he is, he's been teaching him sign and stuff like that, and he sees this bird out there, and he's doing the sign for bird. I was as happy as a parent hearing the first word. We got to experience that again. He was implanted, and on the 1st of September, on Christmas, we took a trip out to Arizona. We were all standing around, people were leaving. He had already started to produce language, words, but to repeat after someone. And people were leaving after a party or something, and he said, bye. Completely spontaneous language of his own production. So we got to experience that whole big thing again, hearing his first words. We got to see his first words, and then later on we got to hear his first words. So we did use sign. Right now, the center, if a parent insists that they're going to sign after the child's been implanted, they say that this isn't the place for you. Yes.
Is there anything that you can't do because you have to go through like sports or?
The doctors would always told us, football's not going to be a really good thing, just because of getting knocked in the head so much, and you're going to have your implant under the helmet and stuff like that. But there are no other sports that you can participate in. You play baseball, soccer, that kind of thing, so you can participate in this sport. I think with scuba diving and stuff like that, they just recommend that you're not going to be deeper than 30 feet. I think with an implant, I don't know if that's still the case. Water is an issue because it's got the microphone. But now the implants have moved in this direction to a lot of them are now water resistant. So a kid can actually have his implant on while he's in the pool. And if he drops that implant in the water, pick it right back up. Now, does that mean he should snorkel and keep that implant underwater for 30 minutes? No. But with us, we used to have issues, especially when he was playing sports, with sweat. Because, he'd just sweat bucket in these hot, humid Georgia summers, and then that would degrade the integrity of the microphone. But now that's much less of a problem, that kind of thing. And so, like I said, even at the pool now and stuff like that, parents can let their kids wear their headset. They don't have to worry about, if it falls or drops into the water, it's destroyed, that kind of thing. And that technology is just going to get better and better. It's changed a lot now.
Does the technology have to be upgraded as a child grows up? Is it kind of thing that has to be replaced?
Well, of course, the internal components can't be upgraded, but the external components continue to be upgraded. Now, my son's original implant that he got in 1994, they are continuing to upgrade some of the external components, but because of the limitation of the technology back then, it's going to reach a point where they can't upgrade it anymore. The one that he has in his right ear, it'll get multiple upgrades to the external equipment, because what they do is they continue to refine the coding strategy, so they make the implants be able to represent normal hearing closer and closer, because an implant does not give a person normal hearing. It doesn't. I mean, my son, he's never heard normal hearing, but if you talk to adults who lost their hearing all of a sudden, and then they very shortly afterwards get an implant, they will tell you the sound I now hear compared to my normal hearing is very mechanical or robotic, that kind of thing. And that's because they're still improving the speech coding strategy of how those electrons fire in the cochlea. And now you can have multiple programs in your little behind the ear. You can have one for music. You can have one for loud environments, that kind of thing. So you can switch sort of the coding strategies that are being used depending on the environment. So the external equipment continues to be upgraded, that kind of thing. So every few years, we say that our son has a Cochlear device. They come out and they say, okay, we've got to upgrade for this. After a few more years, they stop covering the old device, and so you're pretty much forced to the upgrade.
That was my next question. Okay.
Well, in most of the cases, insurance companies pay. The external equipment, the behind the earpiece and the coil, all together usually cost about $6,000. So, every, 4 or 5 years, we're looking at $6,000 to upgrade the external equipment, but insurance covers that. So, yeah.
Is it still a concern for being able to do MRI?
Yeah, I think certain devices are more MRI compatible depending on the strength of the MRI machine and stuff like that. But my son can't have an MRI, especially with his older device. He can have a CT scan, but he can't have an MRI. If it was ever life-threatening, they would have to just do the MRI and he'd have to be re-implanted, that kind of thing. So that is the one drawback. Right. A lot of it, like there are 3 device makers. One of them has a device that's a little more MRI compatible, but you have to be very careful with the strength of that MRI and stuff like that. There have been cases where we know children just had to have MRIs where the doctors will go in and explant the internal device. They have the MRI, they treat the child or whatever, and then they re-implant, that kind of thing.
How many people have been re-implanted?
I don't know those numbers. You have issues like that with someone that's emergent and they have to be implanted. You also have a failure rate of the internal device. When the external device fails, no big deal. You just send off, they send you a new one. When your internal device fails, well, that means explanting that device and putting in a new one. And those numbers vary. The implant that my son has, it's been out for almost 20 years now. They have a device failure rate of like 8%. The new devices, some of them have failure rates of less than 1%, like 0.3%. So the device failure rates are really pretty good. They're comparable with any other pacemaker, other kind of implanted medical devices.
Do they hear any differently when they get reimplanted?
Well, it depends. Like, we've often wondered, my son's older device, which is called Nucleus 22, it's been in there now for 14 years. At some point, it probably will fail. Well, when it fails, they're going to have to put in a newer device because they don't make that device anymore. So we wonder, that newer device will have different electrodes, different coding strategies, something like that. So it may take a while, for his brain to adjust, that kind of thing. Right now, he's got two different devices, an older device in one ear and a newer device in the other ear. They're not going to be producing exactly the same type of sound. But, we've seen children with this where they have the older device, it fails for some reason, they have a newer device, and it takes some adjustment period, but soon they're doing just as well as they did before. Anything else? Any questions?
I just didn't see the dialogue. It looks like there are only 2 people now online right now.
Thank you. You have no other questions?